You're listening to Conferences Online Allergy, Children's Mercy Hospital in Kansas City, Missouri. Today is November 21st, 2025. Our topic today is recurrent fevers, presented by Dr. Tao Lee, Assistant Professor of Pediatrics at Children's Mercy Hospital, Kansas City, and Dr. Nikita Raje, Associate Professor of Internal Medicine, Pediatrics, and Section Chief of Allergy and Immunology at Children's Mercy Hospital, Kansas City.
All right, well, we'll go ahead and get started. So we'll be doing some of our clinical immunology series talks. We did a couple lectures last year. Our topic today is going to be recurrent fever and autoinflammatory syndromes. And so for those of you who don't know me, I'm Dr. Tao Lee. I'm one of the allergists and immunologists here at Children's Mercy.
And I'm Nikita Raje with Children's Mercy and with University of Missouri, Kansas City. Today is November 21st, 2025, where we start our clinical immunology series, and Dr. Lee, take it away.
Yeah. These are our disclosures for today. So for recurrent fevers, looking at fever, it's a common chief complaint that happens for pediatric visits especially. When we think about a fever, typically the temperature that we define in pediatrics is at least 100.4 or more, which we'll talk a little bit in the next few slides as well. Usually when patients come in to a well child or a sick child visit with fever, it's usually thought to be due to an infection, whether it's acute or chronic. But what happens is when these patients have a prolonged, or maybe they're having fevers that seem to happen more frequently than what would be expected for a child, then parents start to get a little bit concerned. Is this always infection, or is there something else going on, or is my child just getting sick a lot, right? Which can be challenging because toddlers, even the healthy toddler, can have illnesses up to 7 to 10 per year. And if they're in daycare, as we all may have some experience with, this can be 14, if not more. And so this in itself, when it is because of an infection, can be really stressful for families. So I think sometimes trying to find an answer can be helpful for them, of knowing like, well, is there something else that's going on that's contributing that can be treatable or prevent it from occurring? But again, in a patient who's having prolonged or recurrent fevers, separate of just illness potentially, I think it's important to have a good high index of suspicion of what other potential conditions that can result in significant inflammation that are not necessarily infectious in etiology. Some of this would include malignancy, autoimmunity, immunodeficiency, and or autoinflammatory syndromes. Now, when we get these patients in our allergy or our immunology clinic, a lot of times these patients may have been seen by other subspecialists already, or are seeing multiple of us at the same time, because they're evaluating for some of these other non-infectious etiologies as well, if that's contributing to the symptoms the patient's experiencing. And some of these specialists may see these patients sooner because of the symptoms that they're presenting with. Say if they're having kind of weight loss, fever, or kind of this prolonged, just generally not doing well, and they have lymphadenopathy, they may see hemonc before they see us, or even infectious disease. But oftentimes you'll find that we'll work pretty collaboratively with one another, because these patients can be pretty complex, and also to make sure that we're not really missing anything. So before we get started throughout the talk, I thought it would be really helpful to kind of look at some overall terminology as kind of a framework to use as we work through some of these different topics. But what I also think would be helpful is going back to the basics with a little bit of a BOS, and I'll try not to belabor with too many details on the inflammasome, but trying to give you a little bit of an idea of like what this process looks like and how some of these diseases are formed as a result of certain gain of function or loss of function mutations, and some of the treatment modalities that are used to treat these conditions. So what is an autoinflammatory syndrome? It's due to inflammation that results in spontaneous cytokine production without an overt trigger. These patients will oftentimes have symptoms with fever being one of them. They may have serosal inflammation, meaning like maybe they have some sort of peritonitis or serositis or pleuritis or something. They can have rash, which can take on a very variety of different forms. They can have lymphadenopathy. They can have arthritis with some obvious like erythema and joint swelling as well. And oftentimes these patients, if you did lab work, would have elevation of inflammatory markers, which would usually be a non-specific finding, but it's just, again, indicative of an inflammatory process that's occurring. Now, how does autoinflammatory syndrome different from autoimmune? Well, when we think about autoimmune conditions, it's a disorder of the adaptive immune system that ultimately results in the production of antibodies or T cells that are reactive with self-antigens. But What I think is also important to know is that there are, even some IEI or inborn errors of immunity, or even like autoimmune conditions that can have a component of inflammatory pieces too. So sometimes it may be one thing, or sometimes it may be both, which is why I'll kind of get into the IUIS classification as well, even though it's not as complete. So when we look at this kind of figure over here, I don't know if you can see my pointer, but this is a figure that's taken from a BOS that I think was really helpful for me when studying and just kind of going through like the different pieces of why this is important and what happens. So what is the purpose, or what is the inflammasome? What it is it's a multi-protein enzymatic complex that usually forms in the cytosol because of infection or cell injury. And the goal is to ultimately activate caspase-1, which is normally inactive, and that functions to go ahead and form active forms of IL-1 beta and IL-18. Usually those are inactive, and so once they become active and are able to be released from the cell is what helps contribute to that inflammatory response. So generally, we think about, well, how is this kind of response process and being able to send some of these ligands there that are kind of occurring? So either there's a sensor protein that recognizes that there's a microbial product, for example, that's kind of going to trigger a cascade of things, or there's a change in the cytosol that's indicative of potential cell injury, whether that's an increase in certain molecules or ions that are telling us, hey, there's something going on here. We need to undergo some sort of cell apoptosis because this is not something that's working anymore. So up here, you have kind of diagram here. There's a lot of different kind of proteins and adapter proteins, but again, I'm going to try to keep it as more of like a big picture just so you can kind of have an idea. But say, for example, you have these sensor proteins, for example, NLRP3, and when the ligand binds to that, that can result in multiple of these NLRP3 proteins to form an oligomer, and each one will subsequently bind an adapter protein. And it's kind of this kind of formation of these clustering of the sensor proteins and adapter proteins that will ultimately allow for subsequent conformational changes that will allow for the recruitment of other proteins. And so in this case, when you have the kind of oligomers forming of this, in particular case, NLRP3, in response to a bacterial ligand or a microbial product, more adapter proteins are recruited, which then allows for kind of the formation of certain filaments of other, and allow for other adapter proteins to kind of cluster together and therefore recruit the inactive form of caspase-1, also called procaspase. As that kind of clusters, more inactive forms of procaspase kind of occur and cluster together, and it's kind of this clustering of them that ultimately results in the cleavage to where that procaspase-1 can become active. When caspase-1 is now in its active form, it then can cleave the kind of inactive forms of IL-1 beta and IL-18 that are normally there and make those more, they'll cleave it to where it becomes the active form so that they can theoretically leave the cell and result in inflammation. Now, a caveat for this is that particularly for IL-1 beta, it doesn't have a signal peptide that allows it to leave the cell. So in this particular situation, caspase-1 will also cleave to make a protein called gasdermin D, which will help formulate the pores in the cell membrane to allow for IL-1 beta to also exit the cell and contribute to that inflammation. So for the IUIS classification, I think in general, it's really helpful to use whether you're doing really anything immunology or autoinflammatory related, because sometimes you get a patient that has symptoms, whether it's infections or fever and associated symptoms, and you're trying to see, well, what things do I want to make sure I don't miss? Because, there are some things that I think we have a nice framework of doing an initial screening evaluation, but then there's some where you're kind of like, well, we don't see these all the time. So are there certain studies that may be more contributory versus one or the other? But this is primarily focused on autoinflammatory syndromes, and it kind of broke it up on the IUIS classification to inflammasome related or non-inflammasome related. And the reason why I think this is important is because as you kind of look at some of these different diseases or syndromes that we kind of work through, some of them are going to talk about a dysfunction within a particular protein or receptor that's directly infecting the inflammasome itself, or it's not affecting it, but there's a different pathway that's allowing for excessive IL-1 production. So these are the conditions that will likely come up if it's something that's going to be directly affecting the inflammasome, which we'll talk about a few of these as well. And I know it's small, but again, the article is really helpful with this type of syndrome or other IEIs that you may be interested in. And then this one is the non-inflammasome related. So one of the examples that I think about is it's not due to an issue with the inflammasome formation itself, but for example, diarrhea, which is a deficiency of the IL-1 receptor antagonist. So basically, if you don't have that presence of the IL-1 receptor antagonist, then it basically allows for just unopposed IL-1 beta function. So then you can just get continuous inflammation. So again, not an issue with the inflammasome, but can still result in excessive IL-1 production.
All right. So with that, we can talk about a little bit about the initial evaluation when you see patients with recurrent fevers. Really, the history comes in really, is really a big piece of your evaluation. And you really want to define that fever occurrence. There are so many patients who come in and say, yeah, there are fevers. You really go into the details of it, and they'll talk about temperatures of 99, 100, and you wonder if they really had an episode that was a true fever. So you have to define the fever occurrence in these patients, and then you have to define the recurrence pattern. How frequent are these? Are they coming at a particular interval or irregularly? And then, define the type of fever, and we'll look at that in a minute. You also want to ask about associated symptoms. Some of these patients can have rashes, including hives, headaches, some eye symptoms. They can have abdominal or GI symptoms, swellings, joint issues, mouth sores. So you really want to go into the details of not only the fever episodes, but also how long the fever lasts, how frequently that's coming in, but also the associated symptoms. The age of the patient and ethnicity can provide some clues. Based on those details, you may think of particular types of recurrent fevers than others. Family history, consanguinity for some of the autosomal recessive cases is important. Talking about physical exam, some of the features that you may notice in these patients might be conjunctival injection. You may see mucosal ulcers, lymphadenopathy, and hepatosplenomegaly that you really want to make sure that you are assessing for hives. So different types of rashes, but hives can be particularly important in some of the disorders, and then signs of arthritis. Apart from the history and physical exam, so in your history, when you're talking about the fevers, you want to know what the temperature is, as I mentioned, but a part of that is to ask how they recorded the temperature, because the temperature can change, or the definition of fever can change based on how they measured it. So the average body temperature, as we know, is 36.8 degrees Celsius, and depending on where the temperature is noted, it can vary from 35.97 to 37, and fever is defined as a rectal temperature of 38 or higher and oral temperature of 38.4 or higher. So that would be 100.4, or for oral temperature 101, that would define fever. Talking about the periodicity or the pattern of fevers, you can define whether these are prolonged fevers, which means it's a single episode in which the fever is continuing to be present. Sometimes it can be present where it is the prominent feature initially, and then it can move lower, be at low grade for the rest of the episode. And so some of the, as you look at the column, and I don't have the pointer, I believe, but in the right column, you can see the causes, how they can differ. If you are looking at prolonged fever, think of Kawasaki's, apart from some infections. If you're thinking of that prolonged fever, initially really prominent, you might want to think about HLH. Talking about recurrent fevers, these are episodic occurrence of fever, and they can go up and down. Lots of infections can occur in that pattern. Malignancies can occur in that pattern. These can be there for a short while, versus they can involve, the fever might be the prominent feature, or there could be an involvement of one organ or different organs, and depending on that, there are various causes that you should be thinking of. IEIs are one of them, but some of the rheumatological conditions can also give rise to recurrent fevers that would look like are involving one organ system or more. Then there are a few other types of fever that you have to be aware of. Fever of unknown origin is a episode of fever that lasts for more than 3 weeks. And in that time, there's no diagnosis after 3 days of full inpatient evaluation or more than 2 days of outpatient visits. And that's your FUO. And then periodic fevers with or without periodicity include autoinflammatory disorders. These are fevers that can last for days. Some of them can last for weeks. But as we talked about the associated symptoms, there might be some of those symptoms present. Some of these fever episodes can be like clockwork. They come exactly in 4 weeks or 3 weeks, and the family can tell you that if they are expecting a fever on so and so date or day. So you have to be mindful of that, and that can give you a clue of what type of autoinflammatory disorder you are dealing with. All right, so apart from history and physical exam, you want to get some lab evaluation to look for the causes of these recurrent fevers. You are getting your basic cell counts, your inflammatory markers, ESR and CRP. You also want to get the workup for other causes of recurrent fevers other than autoinflammatory disorders. So that could include immune workup for IEI, workup for autoimmunity, ruling out infections. And then if indicated if there is a concern for malignancy, then you want to do all of that workup. But in terms of autoinflammatory syndrome, sometimes IgD level and cytokine panel might come in handy. There are times when cytokine panel can really look either completely normal or it is very non-specific, which means the findings may not help you in one direction or another. And then genetic testing comes in handy. It can help you narrow down or confirm the diagnosis of that you are suspecting. Biopsy of affected tissue can also help sometimes. And I did mention serum amyloid or S100 testing. That's likely not available to us here, but some of the countries where it's available, that can be used to look for inflammation as well. All right, we can go into the details of each type of recurrent fevers now.
Yeah, so we tried to pick some of the ones that you may come across more for like your boards or also kind of more prevalent than other ones. But the first one that we'll talk about today is periodic fever, epistomatitis, pharyngitis, and adenitis, also known as PFAPA, which I'll refer to because it's a little bit of a mouthful. But for this, there's an unknown mode of inheritance and also kind of like the overall pathogenicity of it as well. Usually this occurs in patients less than the age of 5. When I was looking at kind of the overall kind of prevalence, it typically will present by age 2 to 5, but there are a subset of patients that will kind of have it present a little bit later in life too. These symptoms are characterized by recurrent attacks of fever. They'll also have pharyngitis, which can just be signs of like significant erythema, and they can also have with or without exudates, which I think is good to know because oftentimes when people see exudates, they frequently will think of like staph infection, for example, but it can still occur in these patients as well. They'll also have epistomatitis, and it's usually those like very painful non-keratinized mucosal ulcers that can be present. They will also have adenitis, usually cervical in nature. And if you were to do lab work, then it could show like a leukocytosis. These symptoms usually last for about 2 to 5 days. And they oftentimes occur at like pretty predictable intervals. So kind of as Dr. Raje was mentioning, there's kind of almost like a set periodicity with it. PFAPA is one of them. Something that's good to know is that usually with this, when you're thinking it's PFAPA, they have these symptoms that look like a viral infection. But I think what will help you determine, is it really viral related or is it something separate, is kind of, again, looking at the history and the diary of the family if they're able to keep one. Because what you're trying to say is that these symptoms are occurring in the absence of an upper respiratory infection, and that these patients are generally doing pretty well and are asymptomatic in between these episodes. Now, in terms of for diagnosis, a lot of times it's a clinical diagnosis, and one of the criteria criteria that I was able to find that kind of came up a lot was the modified Marshall's classification criteria, which you see here on the right. So it again talks about the regular recurring fevers, meaning looking at the periodicity of the fevers and the age of the onset, generally less than the age of 5. The other constitutional symptoms that these patients would have are, again, in the absence of what people suspect to be an upper respiratory infection with either kind of like aphthous ulcer, cervical lymphadenitis, evidence of pharyngitis, making sure that they're completely asymptomatic in between the episodes. And I think these other 2 points are good to note in general, is because in these patients, as a part of your workup, you'll be getting a CBC, but these patients, because of kind of the inflammatory nature of it, they may have more of a neutrophilia, but if they had neutropenia present, then you would have to consider them having a diagnosis of potentially like cyclic neutropenia, for example. And in these patients, they would also have overall normal growth and development as well. Now, the limitation that I was able to find for this classification criteria is that it's not necessarily been validated. I was able to find one that kind of had a smaller sample size of patients that were diagnosed with PFAPA, and there was still overall, I think, like an over 85% sensitivity and specificity, but some of the limitations that it kind of noted on is that there's debate about, for the age of onset. While most patients present between 2 to 5, can these patients actually present a little bit older than that? And yes, that is the case. And I think that's, again, good to know, because some of these symptoms that we're describing as a part of PFAPA will oftentimes be attributed to a viral infection. So again, while you may not be seeing this patient until they're older than 5 years of age, it actually, again, may have been going on a lot longer, but retrospectively, trying to kind of recall that information can also be a little bit challenging. Now, as a part of, again, your lab evaluation for this, we usually do basic kind of workup, as Dr. Raje mentioned, but particularly for PFAPA and also some other kind of conditions, there's not really like a specific biomarker that's going to help you delineate if this is PFAPA or some other autoinflammatory syndrome. But again, on CBC, you may find that there's more of a neutrophilia, or that you'll find that during an acute episode that these patients will have elevation of inflammatory markers. Are they specific to PFAPA? No, but are they suggested that there's some sort of autoinflammatory process that's occurring? Then yes, that would be it. Treatment-wise for this, so if they're having fevers or having kind of some discomfort, you can give them antipyretics. For patients with PFAPA, again, if you have a history that's very suggestive of it, for some of these patients, you can consider doing a single dose of prednisone, 1 to 2 milligrams per kilo, at the onset of an episode. And again, you're presuming that it's not because of an infection of some kind. So again, I think talking through that with families and recognizing it, again, with the periodicity and the predictability of the symptoms that they're having, that this would likely be because of potentially PFAPA. So you give them the steroids at the onset of the episode and see if the symptoms resolve. For some patients, this can be quite therapeutic. And there's only, I think when I looked at some of the literature, there may be a third of patients that only have a partial response. So they may consider doing a repeat dose 24 hours later. In some patients, even if you give the steroids and the fevers improve, sometimes that aphthous dermatitis can last or linger a little bit longer. But what I think is important to know, particularly for PFAPA or as we work through these autoinflammatory syndromes, is that steroids doesn't cure the syndrome. It can help reduce potentially the fever or the symptoms they're experiencing, but it doesn't kind of impact the overall kind of condition of curing it or preventing further febrile episodes. And I think that's good to kind of let families know, because sometimes what happens is by the time we see them, they may have had multiple courses of steroids. And so that may be what they're looking for. But education, I think, is important, because frequent steroid use in itself has risks that come with it too. And in some patients, steroids can actually increase the overall frequency of fever episodes, even if it seems to resolve the symptoms in a shorter period than what it would typically be without the steroids. So outside of just kind of acute treatment, what are some options for prophylactic medications? And I was actually kind of surprised by one of these, and the pathogenesis or how it works is a little bit unclear. But cimetidine, it's thought that could have some sort of immunomodulatory improvement. So there has been a study that's looked at cimetidine use in patients with PFAPA, and it can improve in about maybe a quarter to half of patients after 6 months of therapy. But it was a smaller sample size, and again, it was still pretty unpredictable. So it's a medication that has little less risk, I would say. So it can be something that you can consider in some of your younger patients if you're feeling a little bit nervous. But just know that just because they fail the cimetidine or doesn't respond doesn't really rule out PFAPA either. I was a little bit surprised to see that montelukast has been used for this. I was not aware of that. But again, this was kind of more too small sample sizes with pretty variable data, but has again been trialed in these patients. And colchicine as well has been used, but again, some variability with some of the response with it. Some patients have also used anakinra with improvement of symptoms, but again, these patients may have symptoms about 24 to 48 hours later. One that I think was kind of interesting was kind of looking at the role of tonsillectomy with or without adenoidectomy in these patients. There was a small case series study done in British Columbia where they kind of looked at 9 patients who were diagnosed with PFAPA, and what they did is after they had the tonsillectomy, how did they continue to have symptoms, or when did they kind of reach remission? And they monitored these patients for 2 years after the surgery. What they found is in 8 of the 9 patients that within 3 months of the tonsillectomy, the patients had resolution of their symptoms and they did not have any more febrile episodes. And the one patient that did not have remission by within 3 months of surgery, the overall frequency of the episodes was more prolonged. So instead of every 3 weeks, it was now about every 3 to 4 months instead. But by 2 years, they also still had remission of the overall syndrome in itself. Now, I think what's also important to know is that even without those that get tonsillectomy or some of these therapies, patients with PFAPA can outgrow this autoinflammatory syndrome, usually within 5 years of onset or in their pubertal years. So you can always discuss this with families, and I think kind of gauging how much is this, affecting their quality of life, how stressful is it? Because I think sometimes when kids get sick and they're missing school and it affects a whole cascade of things, that's where it starts to really kind of stress out our families and even, the child in itself, because it kind of disrupts their daily life. But again, I think these are all the considerations you take into place before deciding like what should we try, and then before proceeding with surgery as well. So the next one I have is familial Mediterranean fever, or FMF. This is one of the most prevalent inherited autoinflammatory syndromes. It is autosomal recessive. So I tried to highlight the inheritance pattern of some of these because I think that's really helpful to know, as well as the gene that may be affected. And this is usually seen in ethnic groups that affect in the Eastern Mediterranean coast. Pretty broad range, usually in patients less than 20 years of age. But what I was able to find is that actually 75% of cases will oftentimes occur by age 10. Now, I think what will be good when you kind of go through these conditions is, again, for me, I always like to have the basics of what's kind of happening from an immunology standpoint, but kind of understanding is if you have a mutation, is it resulting in a gain of function or a loss of function? So with this mutation in MEFV, which is good for you to know, on chromosome 16, it's due to a gain of function mutation, which encodes for a protein called pyrin. This is a non-NLR sensor protein that ultimately helps with inflammasome formation. And so basically what happens is when you have this gain of function mutation, it's basically not allowing for a regulation of this inflammatory process, and so it's just resulting in excessive IL-1 beta secretion. And so with these patients, the episodes that they'll have with the fevers is that they commonly will have serositis, with peritonitis being one of the most common ones, or abdominal pain, but it can also result in pleuritis and synovitis, and they can also have kind of like an erysipelas-like rash diffusely on their body, some scrotal attacks or scrotal discomfort, as well as arthritis as well. The abdominal pain that these patients may present with can be quite range. It can be diffuse or localized, and so you'll kind of have to see what those patients think. And again, sometimes depending on the location, they may think it's like appendicitis or something, but really hone in on the frequency of the symptoms and other associated symptoms that may be present. If they're having joint pain, it's usually, it's the second most common symptom for these patients with FMF, and it usually occurs in the large joints of the lower extremities. And after some of the symptoms resolve, this kind of joint discomfort and joint pain is one of the symptoms that can last a little bit longer in FMF particularly. Now, the episodes are irregular. They're not predictable compared to PFAPA, but the symptoms oftentimes will usually last less than 3 days compared to some of the other syndromes that we'll go through. In terms of for A complication for FMF, amyloidosis, is a common one that can occur in about 10% of these patients due to the significant amount of inflammation that occurs. But for your diagnosis, oftentimes it's based on a clinical symptom, clinical history, supported by the ethnic and family history as well, especially if you find that multiple families have it, if they're on the east, if they have Eastern Mediterranean coast descent, then this will probably be higher in your mind in terms of what the potential diagnosis is. Now, if you have patients who have kind of like atypical symptoms where you're like, oh, they have some features, maybe not Mediterranean, who knows, then you can also, again, now in this day and age, genetic testing is certainly helpful, particularly in, just confirming even what sounds like a typical case, but also in patients who may have some atypical features of this syndrome. So if you do genetic testing and they have an attack that looks, or an episode that seems atypical, if you have 2 mutations that are found, then it would be very suggestive of FMF, and you consider doing treatment options, which I'll kind of talk about a little bit below. And then if it's atypical and they may have 1 or no mutation, not all of these patients have to have a mutation, to my understanding, in MEFB, but you can still try to kind of do a trial of colchicine to see if that'll help reduce some of the symptoms. So there's another kind of like diagnostic criteria that I was able to find. It's on the next slide, which I'll show you. It's the Tell-Hauschmer criteria, which has kind of like the typical attack symptoms, some kind of minor criteria, as well as some supportive features. And what it has been pretty validated from what I can tell, but the specificity and sensitivity of this criteria is over 95%. So I think it can certainly be a good guide for you until you're waiting for genetic testing and all that stuff too. For treatment, colchicine prophylaxis has been pretty effective in these patients with FMF. Again, this is the kind of goal, is also to prevent recurrent episodes or these symptoms from occurring. Some of them may have come on steroids when they saw you already, but that again is not going to be something that's going to help for like long-term management of these patients. But you can also consider anti-IL-1 agents, which will kind of touch base on the kind of the mechanisms at the end of this talk. So here's the kind of Tell-Hauschmer criteria for FMF. I found this to be pretty helpful because the major criteria is pretty much summarizing a lot of the symptoms that we talked about in a classic episode. And then there's the minor criteria of some of these other symptoms that maybe they have abdominal pain, but maybe not as severe. Maybe they don't have the signs or symptoms that are consistent with more peritonitis, like if they have like rebound tenderness and all that stuff as well. And then the supportive criteria is looking at kind of the age, their kind of ethnic origin, is there a family history, consanguinity of parents. So I think, again, those can be supportive, but not necessarily as diagnostic, but the diagnosis can be suggested based off of 1 of 4 major criteria, 2 of 5 minor, 1 minor plus 5 of all 10 supportive criteria, or 4 of the 5 specific supportive criteria, which to my understanding was kind of like these up here in this first column. So the last one I'll be talking about today is tumor necrosis factor receptor associated periodic syndrome, or TRAPS. This usually occurs in childhood with the mean age of onset at about 3 years of age. This is an autosomal dominant mutation in TNFR-SF1A located on chromosome 12. This encodes for the TNF membrane receptor, and so this receptor has obviously an extracellular domain that can bind to TNF alpha, spans across the membrane, and then also kind of induces the intracellular signaling once it binds to TNF alpha. When I was looking at the pathogenesis of, how does this gain of function mutation result in kind of the inflammatory response that we see in these patients. One thought is that basically with this typical protein response in a normal variant person, once TNF alpha binds, it can result in the dissociation of this receptor from the cell membrane as a part of regulating the inflammatory response. But in patients who have a mutation in this gene, what happens is that protein, the receptor, may not be able to dissociate, and therefore TNF is resulting in like continuous inflammation, and that's where you get these symptoms consistent with TRAPS. So with these patients, they'll have episodes of recurrent fever. With myalgia, they'll have kind of these like migratory skin lesions, and then the skin lesions can actually be pretty erythematous, swollen, and can actually be painful for some. That usually occur on the trunk and extremities. They can also have abdominal pain, arthralgia of large joints, lymphadenopathy, and with some of them, they can have some ocular involvement with periorbital edema. In some patients, they can have kind of conjunctivitis or episcleritis as well, so kind of doing that full exam can be super helpful. Now, I think what's kind of good to know, and sometimes what happens when we have this overlap between us and rheumatology, who, you know, both of us will kind of look at autoinflammatory syndromes, is that some of these symptoms, especially at this age, may be present in patients with JIA or juvenile idiopathic arthritis as well. So again, it's one of those where you may work together and try to delineate, well, what's going on, especially if you end up doing some of the more diagnostic studies with genetics. Now, TRAPS patients, these symptoms usually last for more than 7 days, but they can last for weeks as well. So I kind of find it to be one of those things where, like, they just look really sick compared to, you know, some of these other conditions, and just kind of looking at the overall duration of these symptoms. And again, amyloidosis is a risk in these patients as well. So if you can help kind of use a preventative therapy to reduce the inflammation, then that will reduce their risk of amyloidosis overall. Now, for diagnosis, again, often clinical, but now with genetics, we may be able to find a mutation that's consistent with TRAPS syndrome. And again, it can be an autosomal dominant mutation. And interestingly, I was looking for a different patient, but I think something to note as a fellow, and just as you do this, is when we do these whole exome testings or immunodeficiency panels, you may get a VUS. Again, a VUS doesn't necessarily mean it's not significant yet, but what I would always encourage you guys to do is to use a PubMed search, look at ClinVar, any of those things, because I actually came across some VUS for one of my patients where there's actually been 4 reported cases of some similar symptoms. So even though it's marked as VUS on your report, the next step that's important for you to do is go through and see, has there been any other publishable literature where a patient is presenting with similar symptoms that this VUS is actually significant and is actually clinically relevant to our patient, right? So anyway, for the treatment, you can use steroids. It's usually effective, but again, the risk is that with frequent steroid use, those patients can become dependent and have systemic adverse events because of it. Immunosuppressive therapies have not proven to be effective at reducing the frequency or intensity of symptoms, particularly for TRAPS. Some anti-TNF drugs, especially etanercept, which is a fusion protein that binds TNF alpha, has proven to be helpful. Interestingly, the medication infliximab has not been shown to be very helpful in controlling inflammation of these patients, but I had a hard time of trying to delineate why. I just know that that was important for me to know when I was studying, so I just wanted to point that out for you guys too. And then obviously for this one, you can also consider using anti-IL-1 therapies, which have also been shown to be effective in these patients too.
Right. The next one in the line is hyper-IgD syndrome. This is caused by autosomal recessive loss of function variants in mevalonate kinase gene that codes for the mevalonate kinase. And this kinase, this enzyme, is important for cholesterol synthesis pathway. Mevalonate kinase, if it's completely absent, so less than 1% of the normal level of the enzyme, would completely impair this metabolic pathway and cause something called mevalonic aciduria, which causes profound neurological compromise and myopathy, versus if there is less of the activity, so more than 1%, less than 10%, mostly 1 to 3% is where you find the hyper-IgD syndrome. If you look at this pathway on the right here, it shows the HMG-CoA or cholesterol synthesis pathway that reduces the HMG-CoA to mevalonic acid, and then the mevalonate kinase converts that to mevalonate phosphate, 5-phosphate. That's further converted, so that one step is not shown by phosphomevalonate kinase to mevalonate diphosphate, which is shown in this pathway. And then that pathway goes down to finally form geranyl diphosphate and then further down to cholesterol. So because in hyper-IgD syndrome, the mevalonate kinase is defective, some of these isoprenides that are geranyl diphosphate and further down are not formed. That causes the inflammasome pathway to be activated, and there is higher amount of IL-1 beta that is released. So you saw the initial picture where we showed you the inflammasome pathway where the caspase converts pro-IL-1 to IL-1 in its active form. And so if there is this geranyl diphosphate that's elevated, is not formed, basically there is a problem with the inflammasome that is overall stimulated, so the inflammasome releases more interleukin type 1. It also leads to formation of more other pro-inflammatory mediators like IL-6 and TNF alpha, and that gives rise to the periodic fevers that we see with hyper IgD syndrome. So how do these patients present? Typical presentation is less than 1 year of age, where they start to have fevers. These fevers last about 3 to 7 days. They come again very periodically every 4 to 6 weeks and are triggered by vaccines, sometimes by infections. So there can be, you might suspect that these are all fevers due to infections, but again, that history would be really important to look for that periodicity, because some of these fevers may be triggered not just by infections, by vaccines, and even in absence of infections, these patients would have these fevers periodically. So how do you diagnose hyper IgD syndrome? So IgD level of more than 100 international units per ml, and we realize that our lab actually measures it in milligram per deciliter, so that cutoff is 14.1. So either of those level, the cutoffs that you use, you have to look for high IgD level twice. But the IgD level by itself does not really correlate with symptoms or episodes. Also, high IgD is not a required criteria for hyper IgD syndrome. So there is a serological diagnosis, which is your IgD level, but there is also biochemical criteria for hyper IgD syndrome, which is checking for elevated urinary mevalonic acid. And then there is the molecular diagnosis, which is the genetic testing, looking for the MVK variant. So all three of those can be used for the diagnosis of hyper IgD syndrome. Apart from that, you would see that with these febrile episodes, the inflammatory markers would be elevated as well. All right, so one more click. Thank you. So here are the associated symptoms that you would see and would help you with the diagnosis as well. So these patients will have fever, but along with that, as you see in this table, this was a study with 103 patients, and the study showed that majority of the patients will have lymphadenopathy. So 87% of the patients had lymphadenopathy. GI symptoms varied from 71 to 85%. So they had abdominal pain, diarrhea, or vomiting. Arthralgia was in 84%, whereas arthritis was present in 55% of the patients. And then skin lesions. So these patients don't have hives, but they can have like a maculopapular rash, and that was present in 69% of patients. Headache was pretty common, 69% of these patients. They can have chills. Some of the patients, so about 32% patients had splenomegaly, 22% hepatomegaly, and serositis was present in 19% of those patients. So again, looking at those associated symptoms comes in handy. This is more complicated than some of the other fevers. For example, the one that I'll talk about next, where these patients can seem like they are having infection because they have these GI symptoms or other issues going on. But the aphthous ulcers that are present in 49% patients, for example, or lymphadenopathy, and the periodicity would come in handy in the diagnosis. Treatment. So again, steroids can be used in these patients, but we would like to use a steroid sparing agent. What I saw is the statins were used more in mevalonic aciduria rather than hyper IgD syndrome. Again, that leukotriene inhibitor, so montelukast, has been used in hyper IgD. I don't think we use it any longer, just because we have better agents that are available. So anti-IL-1 pathway agents are come in very handy and are useful in these patients. So that's most of the times what we use at this point. So we'll look at that information more with the medications as well. But here we'll move on to talk about another fever syndrome. So cryopyrin-associated autoinflammatory syndromes, or CAPS. So CAPS is caused by a gain-of-function variant in NLRP3 gene, and this is an autosomal dominant disorder. This gene and this defect in the NLRP3 gene can cause recurrent fevers. Fevers can be associated with eye symptoms that could be commonly conjunctivitis, but can also cause keratitis or episcleritis or uveitis and can affect the vision. These patients would have joint pain and urticaria. Testing again is very similar to what we talked about in other places. We talked about getting cell counts, which could show leukocytosis in cases of CAPS. They would have elevated ESR and CRP during the episodes. And then serum amyloid A might be elevated as well. Cold-induced urticaria testing can be performed. So these patients have cold-induced urticaria. And sometimes these patients may not have the urticaria reproduced by the ice cube test that we would typically use. So if you use cold water or ice cube, you may not see urticaria. But if you blow air on that area, then these patients would be noticed to have the urticaria there. So that testing can be offered. Skin biopsy, if you do a skin biopsy for the urticarial rash, it would show neutrophilic dermatosis. And then genetic testing can be used to confirm the NLRP3 variant. Treatment again is anti-IL-1 agent, and we'll talk about that in a minute here. And then you want to look out for the complication of amyloidosis, which is known to occur with some other periodic fevers as well. All right, so there are three different types of CAPS that are caused by defect in NLRP3. So the mildest one is called the familial cold autoinflammatory syndrome, or FCAS. This can occur at any age, and these patients will have cold-induced urticaria. Their fever typically lasts less than 24 hours, but again, they can have the other features like conjunctivitis or joint pain as well. Another type is the Muckle-Wells syndrome, which occurs in childhood. So a little older child, and these patients will have progressive sensorineural hearing loss, which can be pretty severe. Again, urticaria can be noticed, and then these patients will also have joint pain or arthritis. And then the most severe form of CAPS is neonatal onset multi-system inflammatory disease, or NOMID, or this disorder also has the name chronic infantile neurologic cutaneous and articular syndrome. And as the name suggests, this disorder starts as a neonate, and again, these patients can have progressive sensorineural hearing loss. They can also have skeletal issues along with the other symptoms that we talked about. So conjunctivitis, urticaria, joint pain can all occur with NOMID. But most prominent feature is the neurological issues, and they can manifest in form of chronic aseptic meningitis, increased intracranial pressure, can also develop papilloedema and can affect vision in that way. And then these patients can have cognitive impairment as well. So again, three different forms caused by the defect in the same gene, which is NLRP3. So moving along, we'll talk about some other causes of recurrent fevers, and you'll see the pattern, or like basically, I'm just going to point out what the difference is compared to what we have already talked about. So NLRP3 defect that we just talked about is a germline mutation or variant in the NLRP3 gene. But sometimes there can be what is known as somatic CAPS, which is a defect that does not occur as a germline defect. NLRP12 defect is called FCAS2. So FCAS is NLRP3, FCAS2 is NLRP12, and this is also autosomal dominant and can cause similar features with fevers and urticaria. FCAS3, so another type of familial cold-induced autoinflammatory syndrome. This is type 3, is caused by something called PLC gamma 2. PLC gamma 2 is causes what is the disease is called PLAD, which means it causes the PLC gamma 2 associated autoinflammatory disease. That causes the cold-induced urticaria. If urticaria can be associated with blistering skin lesions. This particular disorder is a little different because there can be recurrent infections and hypogammaglobulinemia noted in these patients. Fevers, arthralgia, arthritis can be pretty common, similar to other syndromes, and then autoimmunity is another thing to watch out for in these patients with BLC2 gamma defect. A different gene, NLRC4, causes FCAS type 4. This is autosomal dominant, and the important features of, again, in NLRC4 defect, the gene variant can cause severe enterocolitis and recurrent HLH, or it can cause the FCAS4, which is fevers, cold-induced urticaria, and joint pain that looks similar to CAPS. Here, the onset is also as a neonate, but apart from IL-1, IL-18 is also elevated, and in case of an LRC4, IL-18 is extremely high. So that is another cytokine that you may want to check for if you are suspecting an LRC4. NLRP1 deficiency is autosomal recessive and is associated with fevers as well. So these are all NOD-like receptors and defect in that inflammasome. Another gene that can be affected is, we talked about the MVK, mevalonate kinase, but phosphomevalonate kinase. So mevalonate kinase converts mevalonic acid, it phosphorylates the mevalonate. So if the phosphomevalonate kinase that phosphorylates to diphosphate is affected, so the next step in that mevalonate kinase pathway, if that's affected, it causes very similar disorders, similar to hyper IgD syndrome. And these patients can have cytopenias along with other features of MVK defect. This is autosomal recessive, similar to MVK defect. Another autoinflammatory syndrome is TNF-AIP3 defect. This is the gene that causes haploinsufficiency of a protein called A20. So haploinsufficiency of A20, HA20 is the name of the immunodeficiency. These patients will also have fevers, but they may not be as periodic. So they are not, frequently they'll not have a pattern. So you'll see these fevers come randomly. They can't tell you if they are once a month. Sometimes they might be more frequent. Sometimes they will skip a few months and then come back. So it feels like these are not autoinflammatory, but these patients will not have that periodicity. The typical feature of HA20 is oral or mucosal ulcers. So frequently these patients end up in rheumatology clinic, and there is a concern for Behçet's disease. So their mucosal ulcers is a very prominent feature. And they can have eye symptoms as well. And interestingly, there are a subset of these patients who have hepatic involvement. And we had a very interesting patient where our patient had recurrent fevers, but as we followed the patient over several years, their phenotype changed, and that patient developed ALPS, so had cytopenias, elevated double negative T cells, and had lymphoproliferation. So kind of keeping that in mind, that sometimes these patients don't follow the textbook picture of recurrent fevers that we are looking for. Another gene is RIPK1, which is again another autosomal dominant defect. These patients present with cyclic fevers, have lymphadenopathy, hepatosplenomegaly. So this is a similar disorder to HA20, where they'll have mucosal ulcers, they'll have hepatosplenomegaly, they may have increased double negative T cells as well. So again, we just wanted to kind of highlight some of the gene defects that are not as well defined as some of the ones that have been studied for several years that we just talked about, but just wanted to give you a glimpse of the rest of the causes of these fevers. This picture basically brings the overall discussion into, kind of showing and tying that inflammasome pathway into one slide that shows different causes of recurrent fevers. So looking at the inflammasome, there are multiple of the genes that are associated with formation of these inflammasome, including pyrin, NLRP3, NLRC4, NLRP1, and defect in any of these will give rise to various autoinflammatory disorders. You see the NVK that can cause the hyper IgD syndrome that is also associated with inflammasome. So those are all the causes of inflammasome-associated periodic fevers. But then, again, looking at the pathway where the caspase activates IL-1 and IL-18, and that pathway gets affected. So if you have an anti-IL-1 agent, the reason it's effective is at the overall inflammasome-associated disorders finally go through that final common pathway of IL-1, and if you block that pathway, you can treat these patients. And then on the other side, you are also seeing the TRAPS, so TNF receptor pathway. And if that's affected, TRAPS is the most prominent, that's well studied. This is in that pathway. But TNF AIP3 is another one, and there are multiple of those in that pathway that can be affected. So we know some part of, we know and diagnose patients with the disorders and genes that we know about. So the defects in those genes are known, but there are several patients who may not meet the criteria for any of the known genes causing defects, but there's much more to learn. So in those cases where you don't find an answer, so say these patients the patient comes in with recurrent fevers, they have elevated inflammatory markers with those fever episodes, but they do not have a known monogenic cause of those recurrent fevers. These are not from infection or malignancy or autoimmunity, and they don't meet criteria for PFAPA. In those cases, we diagnose them with something called syndrome of undifferentiated recurrent fevers, or SURF. So this is relatively a newer term, but is very widely used at this point, and you'll find literature for these this term SURF, where these are the patients where we don't yet know what's causing their recurrent fevers. The important piece to this is that if we are able to hone into the fact that these are patients who have autoinflammatory symptoms, but not necessarily any other treatable conditions like infection or malignancy, then you can start working towards giving them treatment like anti-IL-1. These patients can have additional supporting features, but the mandatory features are what I mentioned, and they'll have similar features that we talked about. And another important feature is their response to anti-IL-1 therapy.
So kicking off some of the treatments, so optimal therapies and autoinflammatory syndromes, the goal is to decrease the chronic inflammation and prevent acute flares, with also the goal of being safe to use for extended periods, hence why we don't always like to have them be on steroids. But steroids in some conditions can be helpful in acute flares, like we kind of discussed a little bit with PFAPA, but again, not ideal for long-term management or prevention of the overall condition that comes with side effects as well. Cimetidine has been something that can be used. It's technically an H2 receptor blocker, so wouldn't have thought to use it in these conditions, but can be considered for treatment preventatively. It's usually 20 to 40 mg per kilo per day, divided BID, and the side effects are pretty benign. So I've actually done a trial of it in some of my patients with real small amounts, but one that has had some degree of improvement. But I think if you consider starting this therapy, not all places, especially in pediatrics, may have it as a oral suspension. So that may be something that requires some coordination with our hospital. But it's certainly an option for some of them as a trial, especially if you don't have a clear diagnosis before kind of going to kind of like anti-IL-1 agents and stuff like that. Colchicine, classically I thought of this as like a gout medication when I took care of adults, but there is some thought that it can affect and improve some of these autoinflammatory symptoms because it impairs the cytoskeleton formation, and so it therefore can kind of disrupt the overall basic cellular function and the chemotaxis, and thereby kind of affecting the overall inflammasome formation, because if it can't form properly, then those other downstream things that we talked about will therefore ideally not be able to occur. The dosing for this would be 0.5 to 1.2 mg per day. But again, this is one that I also, again, for pediatrics, had a harder time finding a liquid suspension. So you'll have to coordinate with our pharmacy if you're trying to do that as a trial. Colchicine does have a little bit more side effects in terms of its use. It can cause myalgia, can cause acute toxicity. In some patients can result in pancytopenia and hemolytic anemia and thrombocytopenia. So you'll probably get some baseline labs and then also monitor them every few months or a little bit longer, depending on what your comfort level is and if you're going to be a little bit more conservative. Colchicine can also have drug interactions with other medications, especially if they're metabolized by CYP3A4. So you'll want to see what other medications they are on, because that can affect the overall level or kind of the effectiveness of their other medications depending on what they're on at the time.
So the anti-IL-1 pathway agents include anakinra, canakinumab, and rilonacept. Anakinra is a receptor antagonist. It is rapidly active, but it needs frequent administration, which is a daily injection, 1 to 2 milligram per kilogram. For anakinra, before you start this medicine, you want to get TB testing and serum creatinine at baseline. And then these patients would need CBC monitored every month for 3 months, followed by every 3 months for 1 year. The common side effects includes injection site reactions, and then if they do develop infection, they would need to stop anakinra temporarily. There are studies looking at using anakinra just for on demand rather than continuously. That would be helpful. But again, there is varying response to that. Canakinumab is a fully human monoclonal antibody targeting the cytokine itself, IL-1 beta. These are subcutaneous injections, 2 milligram per kilogram per dose, given every 4 weeks, can be used every 8 weeks. And the only big issue with canakinumab, it needs to be administered by nurse, so there should be a home care nurse set up so that they can go and give this medicine. Rilonacept is weekly subcutaneous injection, and again, injection site reactions is what you watch out for. Okay. So this is basically just going over the clinical outcomes of these inhibitors in different disorders. So in FMF, it shows that these inhibitors are useful in about 60% of adults, but is really effective about 81% of the patients, pediatric patients. In CAPS, again, IL-1 blockade dramatically improves the symptoms and prevents organ damage and is considered first-line treatment. TRAPS and hyper-IgD, they respond pretty well. And then again, we talked about the safety issues with some of these agents. I think that's the last slide. Any questions?